Hello, my name is Tan with SRNA at Berry University. Today I will demonstrate a comprehensive difficult airway assessment using a focused physical examination and a point-of-care ultrasound. This assessment performed before induction to identify patients who are at risk for a difficult endotracheal intubation. I have a patient here presenting with obstructive sleep apnea and limited neck mobility who is scheduled for an elective abdominal surgery. So his medical history places him in an increased risk for a difficult airway. Therefore, a detailed preoperative airway assessment is indicated. So my differential diagnosis include a normal airway, predicted difficult laryngoscopy, difficult mask ventilation, limited neck mobility, and the upper airway obstruction related to his sleep apnea. So the body system involved include the head, the neck, and the upper respiratory system. So for this assessment, I will utilize a portable ultrasound machine, a high frequency linear probe, ultrasound gel, tape measure, and a pen light. So first, I will have a patient sitting up, and then I will perform a Malam party and incisor distance. So can you open your mouth as wide as possible and stick your tongue out? Stick your tongue out without speaking. Okay, good. And I'm gonna put 3 fingers close here. Okay, good. So I can say his Malam party is 1 because I can visualize his soft palate, his hard palate, uvula, and his tonsillar pilus. And then he has a normal incisor distance because it's greater than 3 finger breadth. So incisor distance tell you basically it helps to predict whether there will be enough room during intubation. And then I'm gonna measure the thyromental distance. Can you attend the next for me? So from the thyroid notch to the mentum right here, distance greater than 6.5 centimeters indicate there will be adequate space for laryngoscopy. And then can you attend your neck for me? And then flexion like this. Okay, good. So cervical flexion and attention. So I'm assessing cervical flexion and attention, and this will help to improve visualization of the vocal cord during intubation. And then next, I will have the patient lay down for me in the supine position with a neck in the neutral, and then I will select a high frequency linear probe because the neck structure are superficial. And then I'm gonna apply the ultrasound gel, and then I'm gonna apply this transducer perpendicular to the trachea, just right above the suprasternal notch on a transfer orientation. So first I will identify a trachea which is appear at the bright hyperechoic air mucosal interface with posterior reverberation artifact. And then I will identify the thyroid gland, which will be at the homogeneous medium to high echogenicity tissue. And the thyroid lobes are attend laterally. So I'm gonna slide the transducer superiorly to identify the cricoid cartilage, which recognized as the only complete cartilaginous ring of the airway. Above it is the thyroid cartilage, which is larger and has an inverted V appearance. So between the cricoid cartilage and the thyroid cartilage is the cricothyroid membrane, which is seen as a thin hyperechoic line, and this is the most important landmark for emergency cricothyrotomy. Okay. So a normal finding include a Malam party 1 and 2, an adequate mouth opening, a normal thyromental distance, full neck attention, and with the trachea in the midline. And then abnormal finding include a Malam party 3 and 4, limited mouth opening, short thyromental distance, and limited neck mobility with a distorted airway anatomy. So in conclusion, combining physical examination with ultrasound will improve airway evaluation and have established a set and a static plan. Thank you so much.